that are compressed. It is a barrier. It is slightly less effective for pregnancy and for preventing disease. By the way, it's slightly better for herpes. Anyone know why? Because it covers the outer lips, which are mucous membranes and easily susceptible. So it's slightly better for herpes and HPV than the male condom. All right, and then we have the Mentor condom. A lot of guys like this one. And that's a condom made by 3M Corporation. What does 3M make that you touch almost every day?
Tape.
Mm-hmm. And what does tape have on one side?
Adhesive.
That's right, and that's what this condom has. It's a glue. It's a water-soluble glue. And so it comes in a 1-inch box. And inside this box is something that looks like this. It's a very weird appearance. It's this heavy plastic device that looks like Tom Terrific's hat, if you ever saw way back when we had those cartoons on.
Yeah.
And what you do is you put the penis up in this, and you pull the hat off, and then you roll down the condom. This is an applicator. A lot of people we had trouble with, they thought that was the condom. And it's very heavy plastic, and you wouldn't feel anything. And they left it on during sex. It's really gross. This is just an applicator to place over the end of the penis, and then you pull the applicator hat off and roll down the condom. And it has a water-soluble glue that glues the condom, because many people said the condom slips off and then you have to go hunting for it. Diving in the vagina, looking at periscope. Oh, there it is. All right, so this one, disadvantages is it's a little bit of cost. I mean, it's $3 for this thing. But it's also latex, so you have to use a water soluble. That's another disadvantage. So you have to have your water soluble lubricant. And then the last disadvantage of it is that if you roll it on, you got to roll it off. You see, most guys, when they're finished, we're done. We don't want to kiss, we don't want to hug, we don't want to discuss things, we don't want to lay there and cuddle. We're done. Hand us the remote and leave us alone. And what happens is when guys are done, they reach down and they grab that condom and they jerk it off to throw it in the garbage. If you jerk this one, you will jerk your thing off. It will not come off. So if you go like this, you're going to be stretching it that big. And it's going to hurt. So remember, if you rolled it on, you got to roll it off. Get it off. So it can cause difficulty in removal. Follow the directions, like I keep telling you, read the directions. Alright, advantages, it doesn't slip off. It'll never slip off. So, anyway, anyone have any questions about how to use condoms properly, what the advantages and disadvantages of everything is? The big advantage of the skin condom is it transmits feeling better. The big disadvantage is it's got holes as big as viruses. Your question?
Oh, who ended up winning that contest?
What now, huh?
Who ended up winning the contest?
The guy who made the bag. Cheap, easy. Didn't need very much instruction. Those panties would have driven us nuts just writing the instructions. All right, so these are the safer sex guidelines. Oral sex is not 100% safe. Know your partner very well. Make sure if you're in a committed relationship, you go and get tested. And remember, men are pigs. Men will always be pigs. Never trust one. Now, you can have, men will be good sometimes, but remember that if they get tempted, they might give in. And so the best thing you can do is watch them all the time. Avoid multiple sexual partners, get tested and share the results, and remember that any pre-cum or vaginal secretions, if it's high viral load, are infectious. So now we're going to talk about testing. And remember, there are two kinds of tests. If you're looking directly for the agent of disease, the bacteria or virus, that's called direct or antigen testing. Anything that turns on your immune system is an antigen. So that would be a virus or a bacteria or something like that. And then if you're looking at the body's response to a foreign agent being there, that's an antibody, and that's called indirect. So indirect testing is very good, very accurate, and very cheap. But it always has a big problem. It takes 90 days for antibodies to develop. So the huge difficulty with indirect testing, it's cheap, it's accurate, it's good, can be used on huge numbers. But the big problem is they're always time delayed. Time delayed. So which of the tests that we're going to be talking about are indirect? The Elizas, the fluorescent antibodies, the Western blot, and all of these rapid tests like the one with the lollipop or the drop of blood that they now use. All of them are indirect, looking for antibodies. The direct test is either very bad or very good and very expensive. So there is one direct test that is very cheap but very bad. And it was designed for tissue culture or cell culture. Who can tell me what that is? Growing viruses in a liquid environment in those flasks. It was designed to see if your virus is being produced in a flask in huge numbers. So it's not really good for use on people. So these are the direct tests. It's called a P24 direct antigen, and it's also called the reverse ELISA. Now remember what the ELISA is. You take a plastic plate, you coat it with the antigen or causative agent, you add patient antibodies and horseradish peroxidase enzyme, and if the patient has antibodies to what's on the plate, this will turn yellow. And if they don't, it'll remain clear. So a reverse ELISA would be you coat the well with a patient's antibodies. And then you put blood plasma and horseradish peroxidase. And if there's enough virus particles in the plasma, it will turn this a dark color. But remember, we're talking about things 100,000 times smaller than bacteria, so there's not going to be many in plasma. So this is not a good test, the reverse ELISA. We'll talk about it in a minute. All right, so let's go over, does everybody understand the difference between indirect and direct? Indirect is very accurate, very sensitive, but time delayed. Very cheap. It's antibody testing. Direct testing is where you're looking for the agent of disease, the causative virus or bacteria. In the case of viruses, they're so small that the direct tests are either very expensive or very bad. So, the third kind of test, remember I told you there was indirect and direct, then there's sandwich. And sandwich is a mixture of direct and indirect. So this one is used by the Red Cross. And the reason the Red Cross does it is because, and by the way, you can't get one. So if you want to know, if you would like to use the sandwich assay, you can't get one because you can't get tested by the Red Cross for fun, for free. Here's what happens. If you go to the Red Cross because you're a coward and you don't want to go out of the closet and find out, you want people to think you're wonderful because you donate blood. And it's really because you're a ho-ho and you want to find out if you're positive. And you go donate blood, they won't tell you you're positive because they don't want to encourage people to go donate blood that might be in the window and test negative but be positive. So here's what happens. Let's say you are a ho-ho. You know, you're out there just screwing right and left and not using protection. You're so infected, you know, your head just about blows off. And you go to you don't want to go to outer closet because someone will know you're a ho-ho. So you go to donate blood because you want people to think you're wonderful. And you donate blood and the Red Cross finds out you're positive. They will send you a letter. And it says, "Dear Dr. Hicks, thank you so much for donating blood at the LA City College Blood Donation Drive. It's people like you that make the world go round. By the way, in testing your blood, we found that your blood was positive for one of the 15 diseases we test for. Some of these diseases can be treated. Some of these can be cured. All of them may be treated. Please see your doctor at your earliest convenience. Love, the Red Cross. P.S. Do not attempt to donate blood again. Your name and social security number has been registered in an international database. Should you attempt to donate again, you will be arrested. Love, the Red Cross." So, they will not tell you that you're HIV positive. They'll just say your blood was positive for one of the following: hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis F, hepatitis G, all of the diseases they test for. But they don't tell you which one. So, and why? Can anyone explain? Because I'm going to put this as a test question. Why doesn't the Red Cross tell you?
Because if they're wrong, they can be sued.
No.
Because it can be delayed.
Because people would go there to get tested and they would be donating while they're in the window. The blood would be positive, but it would test negative, and more people would be infected. Because it takes 90 days.
So Red Cross don't know?
They know that. That's why they don't want anyone donating blood that thinks they're positive. If you've done something that makes you think you're positive, they don't want you to donate because the test won't, detect it. Well, their test is really good. Look, it can get down to day 10. The antigen test can get down to day 7. So this test is extraordinarily good. Here's what they do. Remember, every time virus gets into your body, what does your body make to it? Antibodies. And what do those antibodies do to the virus? They stick to it. When they stick to it, the antibody is now taken out of the bloodstream and not available for the test to measure. Everybody get it? So every time virus replicates, it sticks to your antibodies, and all the antibodies are removed from your bloodstream until more antibodies are made. The virus is there. So they add an enzyme to blood that separates antigen from antibody, making antibody available for the ELISA to detect. And then they also run that horrible P24 test on the antigen. So what they're doing is they're adding an enzyme that separates antigen-antibody complex, making more antibody available for the test to detect. And it's a really good test. And it's called sandwich because they're not only looking for the meat, but for the 2 pieces of bread, which is the antibodies. So they run a bad P24 test as well as an antibody test on the blood after adding an enzyme that does what? Separates the bound antibodies. Separates the bound antibody. So this is incredibly good test. But can you get it? No. You can't go to any doctor or any clinic and get this. Only Red Cross uses it. Only Red Cross licenses it. And if you go and donate at the Red Cross, they still won't tell you. Alright, so those are the 3 kinds of tests. Antibody test, which are called indirect. Antigen test, which are called direct. And sandwich, which is a little bit of both. Alright, so let's talk about the ELISA. I've already told you. You coat the plastic well with the virus, and you add a person's antibodies and horseradish peroxidase. And it will turn a color if it's positive. And by the way, we run 2 wells on every person. So we run a negative and then 2 positives. We run a high positive, a moderate positive, and so we run controls with every plate. And we always run a negative, and then we run positives, so that there's always a control in there to make sure. Now, this test is 99.9% accurate. It means that if there's enough antibody in there for it to detect, it will detect it. But it over-reports. Does anybody remember what I was talking about when I said it over-reports? If you have a number scale where everything above 0 is called positive and everything below is called negative, what do you do with the top 10% of the negatives? Remember, people are gradually converting from positive to negative if they got infected 3 months ago. So they are moving. What do you do about these top 10% of the negatives? They are either somebody who's about to convert to positive, or they are something else. So we do not want to transfuse blood that's about to turn positive. So what we do is, in the laboratory, we tell the lab that if somebody is in the top 10% of the negatives, to report it as positive. Not to report it to a person, but to the lab. Now what happens to the positives? All positives are retested. So remember, if you come out positive or positive borderline, what's the next thing they do? Another test. If you come out positive or positive negative, then they send you to the next test, which is Western blot. So everybody gets 2 Elizas. Now if you're negative on the first one, they don't do anything else. They just report it to you as negative. But if you're positive or borderline, you get retested. If you're positive or borderline on the retest, it goes to the second level of testing called Western blot. Anyone unclear? Okay. This is the quick test. You can read through it, but these are all those little tests that they do at the testing center with a drop of blood, or they do an Eliza on a stick with a lollipop, and it just tells you which ones are approved in the United States. The only thing you have to know about this is all the rapid tests are indirect. They're all indirect tests. They're antibody tests that have to be confirmed if you're positive by a Western blot. They're called rapid tests. All right? So, guess what? California's different. I bet you knew that. The state of California has its own testing protocol for HIV. If you're positive or borderline on an ELISA, it's repeated. If it's positive or borderline again, they send it to fluorescent antibody testing. Fluorescent antibody testing is where you take a fluorescent slide, and it's a slide that looks like this. It's a regular microscope slide, but the whole slide is covered with plastic except for 12 wells. These little wells are the size of a pencil eraser. And on each one, we put HIV-infected white blood cells. Put a drop on each one. Let it air dry. Then we add patient antibody, and fluorescent dye. Now, if antibody sticks to the infected white blood cells, the dye will stick to that. So here's what we run. We run a known positive and a known negative for 2 wells of each. Then patient number 1 gets run twice, patient number 2 twice, patient number 3 twice, and patient number 4 twice. So on every slide, there's a positive and negative control. And if you put it under a UV light, and you have antibodies to the white blood cells that are on the slide, it will glow under UV light. If you don't, it'll be black like this. And this is called fluorescent antibody, and it costs 25 cents. The Eliza cost $1 a piece. So, then the fluorescent antibody, this is Eliza. And the Western blot is $75. So everybody that's positive has cost the state of California how much? $76.25. $2 here, 25, that's $2.25, so, oops, $77.25, sorry. You've had 2 Elizas, 1 fluorescent antibody that was positive, and the Western blot was $75. Now the rest of the states do not do fluorescent antibodies. 49 states, this is going to be a test question because I will say, I'm in Puerto Rico, and I have I've had a borderline Eliza twice. What's my next test? It's going to be Western blot. But if you're in Sacramento, what's the next test?
Fluorescent antibody.
Fluorescent antibody. Why? Because the federal government says that you have to have 25 years of fluorescent antibody microscopy experience to read fluorescent green from black. And they say that they don't trust that the different state laboratories can read fluorescent from black. Now, why does California get away with it? And the answer is, we have our own FDA. Back in the early days of scientific research, the state of California set up their own FDA for human research and testing. And it's called the Bureau of Biologics. And it regulates every laboratory and every experiment done on humans in California. And the U.S. government got outraged by this. And so they took it to the Supreme Court, and the Supreme Court said, read your Constitution. All powers not specifically given to the federal government are reserved to the states. As a result, the U.S. government does not have regulatory power over our Bureau of Biologics. Now, the Supreme Court made an exception, well, not exception, but they made a comment, and they said, so long as the regulations are as strong as the federal government or stronger. So if you're going to try out a new drug on people, do you want to put it through 15,000 bureaucrats in Washington at the FDA or 500 in Sacramento? You want to do it in Sacramento, which is why almost all drug testing is done in California. All these human experiments and all that is done in California because we have a closer drug system. They regulate it more carefully and a much smaller bureaucracy to go through. And so long as we don't test anybody else's blood from another state, we can do what we want within our borders. So remember, it's because the Bureau of Biologics sets regulations that are stronger than the federal government's one, that we get to do our own thing in California. Now the funny thing is, every other country in the world uses fluorescent antibody. In Japan, they have a machine that reads these, and they recognize it as legal for HIV tests. But for some reason, the FDA here says that you have to have ridiculous levels of experience to read these. All right, let's look at the Western blot.
Can I ask you a question? So for
Yeah.
California, you do 2 Elizas, the Western blot, and then the fluorescent?
Right. If the Western blot glows or you're confused and you can't tell if it's glowing or not, then it goes to Western blot.
Oh, the Western blot is after.
Yes. Always the last level is Western blot in every state. All right, so what's the Western blot? You take a piece of paper and you put it in a plastic well and in that well you put saline. And then you put whole HIV, and then you put a detergent. Now detergents break HIV into the individual proteins. So then you put it on an electrical charge overnight, and the proteins migrate according to their molecular weight. They spread out on this sheet of paper. And the lightweight ones move toward the positive, and the heavy ones stay down at the negative. And so they migrate during the night, and the next day you come back and you still got a white sheet of paper. Then you add patient antibodies, or patient serum, which has the antibodies in it, and horseradish peroxidase. And if you have antibodies to the different proteins in HIV, it will show up as a black line. Remember those numbers of antibodies that we had? There they are. GP160, GP120, 55, 41, 31, 24. These are specific, and you have antibodies to the protein that's on this strip of paper. It shows up as a black line. So this is what we call a marker. We always run a marker. And then we run a negative control, and then we run the patients. And so this is the negative control. This is someone that doesn't have any antibodies to HIV. This is a patient that doesn't have any. And this is a patient that has 1, 2, 3, 4 bands. Are they positive?
Yes.
Yes, you have to have 3 bands. So what if somebody only had 2? Then they would be in the window, come back for further testing. Why don't we say if you have any bands for HIV, you're positive? Answer, because the Asian flu can give you a P24, and being pregnant can give you a P55. Both of these will disappear. So the rule is to be considered infected with HIV, to be legally and medically infected, you are HIV antibody positive, Western blot confirmed with how many bands? 3. 3 or more. If you have 1, you're indeterminate, in the window, come back for further testing. If you have 2, indeterminate, in the window, come back for further testing in 3 to 6 months. If you have 3 or 4 or 5 or 6 or 7 or all the way up to 15, you are HIV antibody positive, Western blot confirmed. Confirmed means you have 3 of the bands that tell you that you are HIV positive. Okay, so anyone have any questions about testing? All right, let's go to direct testing. Direct testing means you're looking for the virus. There is the reverse Eliza, which I told you is cracked. Then there is the viral load 1 and the viral load 2. Viral load 1 was a PCR, polymerase chain reaction test, the DNA test, looking for viral DNA in your blood. And the first one that came out really wasn't so good. It could detect something like 10,000 particles per mil. And the one that just came out, let's see what it is, down to 2,000 copies per milliliter of blood. And how many does it take to infect a person? 250,000. So remember viral load 1, the first generation test can only get down to, what was it, 20,000? Yeah, 20,000 copies per mil. Viral load 2, which is the one they're using now, can get down to 2,000 copies per milliliter of blood. Is there any test that can get 0? No. That's what is meant. There's a test question that says, what's meant by the statement 0 ain't 0? When Magic Johnson's wife, remember the whole story about him, he got his yearly checkup for, you know, being a Laker or whatever it was he was basketball player, and he was negative. And then he and his wife got pregnant, takes two. She was pregnant, but he helped. And they decided they wanted more life insurance because they were having another baby. So they applied for a larger life insurance policy and found out that he was HIV positive. Now, there was only a few months between when he had a negative test and a positive, so he could go back and say, and he admits he was a ho-ho. He was out on the road and his wife wasn't there, and all these wonderful girls come by and throw themselves at him naked, and he partook. So he knows how he got infected. Let's hope it wasn't IV drugs. But anyway, he is richer than God. Well, maybe almost as rich as God. And as a result, instead of having to wait until he first shows symptoms or gets 500 T cells, he got immediate treatment. You know, but remember, treatment is $100,000 to $250,000 a year. And if you get it, your insurance, or the state of California, if you don't have insurance, will not give you medications until you have 500 T cells. Half of them are gone, because the normal's 1,000, so you'll have 500. He got it immediately. The moment he turned positive, he got the best drugs available, and he's been treated ever since, and he's kept his viral load at 0. So one day, the newspapers asked him, how come your husband hasn't gotten sick and died like everybody else with HIV/AIDS? And she said, because he took the medications and he's cured. They can't find the virus in his body. He wasn't cured. He still has the virus. It's just they can't find it with this machine. Remember, the machine will call 0. 1999 means that you're 0. But you have 1999 particles because that's as low as it can measure. Yeah. So, remember, 0 is not 0. It's not actual 0. It's just as low as our machine can now measure. And it used to be, remember, 0 was 20,000. So our machines are getting better. Our tests are getting better, but 0 is not 0. All right, so let's talk about the different tests. Let's talk about the reverse ELISA. You already know what it is. You coat the plate. We actually go to people that are positive and buy their antibodies. We coat the plate with P24 antibody that we buy from somebody that's positive. And then we add blood plasma, because plasma has more viral particles than serum. And we add horseradish peroxidase. And it's called a reverse ELISA because we're not coating the plate with the virus, but coating it with an antibody. Coating it with antibody, and we're hoping there's enough virus in plasma for it to capture the virus particles and turn dark. And of course, virus particles are very rare and very small, and there's, you know, it's unlikely. So, when does the P24 test turn positive? Here's the viral timeline. You got infected on day 0. At 14 days, you had the viral flu, and then your viral load went down until your body starts killing more T cells than it being made, and it goes straight up. So about here is when you got 500 T cells. So when does the P24 test turn positive? It turns positive here and here. What is that? 15 years after infection and on day 14. So, if you took a P24 test, it would be negative all these 15 years until you were near death. So, it takes a huge amount of virus for a P24 test to be positive. It wasn't designed for human testing. It was designed for cell culture, growing it in a flask and detecting virus production. So it's used, you won't believe this, what this is used for. Hysteria. People get needles stuck and they're hysterical. And you can't tell them, well, you're going to have to wait 3 months for a test. And then you say, well, do you have $1,500 in your pocket? We can get it in 2 weeks. And they're going, ah, ah, ah. They're wanting to jump off bridges and they got to wait 14 days. How do you calm them down for 14 days? You give them a 25-cent HIV P24 test, which you know is going to be positive. I mean, no is going to be negative because they would have to get a huge viral load. But it keeps them calm until they can get the real test that really works. I know it's not a very good thing to do, it's a little deceptive. But, you know, you don't want people jumping off a bridge if it's not necessary. Okay, so remember the P24 test is not very good except for tissue culture, which is what it was designed for. It does detect a huge high viral load, but that is unlikely in an accidental exposure. Now, where else do we use it? We use it in places where there is no electricity, so you can't run the other test. It's just a little Eliza. So if we go to Ultra Volta and we do a quick test, rapid test, and find out somebody's positive, and we hand them 3 months of medication and say, take one of these every day, and we come back 4 months later, we take a viral load to see if it's gone down. So in third world countries where there is nothing else, no electricity available, we take one when we find out they're positive, and we take one after we give them medications when we come back a couple months later. So, who can tell me what the 3 appropriate uses of the reverse ELISA are? Hysteria. Third world countries. Tissue culture. Production labs. All right, so that leads us to the last topic, and that is the last 2 topics is treatments and vaccines. Treatments and vaccines. So, we're going to talk about the different drugs as they came out, and we're just going to talk, you're not going to have to know the names of the drugs, so don't panic, but you do have to know the classes. And so the very first drug that came out, we're going to call this drugs, the very first drug that came out was thymine nucleoside analogs. Now, who can remember what an analog is? It's a fake DNA or RNA base. This is fake thymine. This was AZT. It was the very first antiretroviral agent. AZT. Thymine nucleoside analog. And it works best in what we call activated T cells. T cells that know they've been infected but are rapidly dividing to fight infection. AZT works best in them. Activated T cells. You know, T cells are wandering around in your blood, about 1,100 per milliliter, and they've been infected by HIV, and that triggers them to divide. Now that's not good, because they're dividing and they're already infected. So that's what AZT works best in. Activated T cells that are rapidly dividing, thinking they're going to fight infection, but they're already infected. All right, the next drug that came out was non-thymine nucleoside analogs. So other than thymine, another base. This is DDI and DDT, DDI and I forgot what the other one is, but it doesn't matter. They're non-thymine, but they're still fake bases. And what do they work better in? non-activated, or let's say inactivated, no, resting, that's what we call them, resting T cells. These are T cells that are not, that don't know they've been infected. And they're not rapidly dividing. They have been infected, but they just don't know it. These are infected and do know it and are rapidly dividing, thinking they're going to fight it. These are infected, but they don't know it, so they're not rapidly dividing. Okay, so two different kinds of T cells. Ones that are rapidly dividing and one that are not. Both are infected with HIV, but a different kind of medication. All right, the third kind that came out was non-nucleoside reverse transcriptase inhibitors. And these are called NNRTIs. And what they do is they encircle reverse transcriptase and block it. They get around that reverse transcriptase and don't allow it to convert viral RNA to viral DNA. Remember, that's what reverse transcriptase does. It's an enzyme that only exists in class 5 retroviruses. And if you block it, then the virus cannot convert to DNA and insert into your cells. So that's NNRTIs. All right, the fourth class was protease inhibitors. Inhibitors, sorry. Now, this drug right here changed the world for people with HIV. Before this, the first 3 classes of drugs, people didn't get any worse, but they didn't get any better either. They lingered, and it was awful. And they were losing weight and going, getting wasting syndrome and all of that. And here's the example that I use. It was just shocking to me. A friend of mine was HIV positive, and he kept getting worse and worse and worse and worse and worse. And one day I got a call, come to Kaiser on Sunset and say goodbye, because he will be dead before the end of the weekend. So I went up there, and this guy was the same height I was, but he was like 240 pounds solid muscle before. And this guy was something like 70 pounds. He had wasted away to nearly nothing. Didn't recognize anybody. The priest was already in there and had given him last rites. I said goodbye and, you know, felt really bad about it, but the way I deal with things is I don't think about it. So, yeah, put it out of my mind. I didn't think about it. 6 months later, I got a card in the mail saying, would I come to a party celebrating his 30th birthday? And I called up and I said, what is going on? And they said, they got him protease inhibitors by emergency, and he's fine. And you look at him, and he won, 2 years later, he won Mr. California weightlifting. And he walks around, he's just fine now. Yeah, he's still got HIV, and his T cells are right at about 250. But he got up from the dead and walked. All because of protease inhibitors. Now the reason is what we call the 3-drug cocktail. It is the first of our HARRT, highly antiretroviral therapy. And here's what happens. They give one of these, and one of these, and one of these. Any of these 4, they give you 3 of them. And think about it. If somebody is about to rape you, and they're coming at you with a baseball bat from one direction, you can fight them off. You might get a broken arm or two, but you can fight if somebody's coming at you in one direction. And maybe even two. But can you fight them with 3 directions? They're attacking the virus in 3 genetic directions, so that it cannot orient its massive mutational ability to mutate around a medication. If you attacked it in 3 directions, it can't mutate. And that's what the miracle drug for HIV is, the 3-drug cocktail. And the one that allowed it was protease inhibitor. Now, what do protease inhibitors do? They block assembly and release. Remember the steps? Adsorption, penetration, synthesis, maturity, and release. They block maturity and release. The virus needs a protease enzyme. Remember, it makes a long protein, then it puts its RNA or DNA inside that capsid. They have to cut that capsid into links that it can then form that little circle that protects it. That's what a protease inhibitor does. It blocks that cutting into correct links of the protein capsid for assembly and release. So it made all the difference in the world. So that's the 4th one. The 5th drug that came out was what we call fusion inhibitors. And if you go online, they're also new. There's some new fusion inhibitors. But the first one was Fusion. And it was a fusion inhibitor, and what it does is it blocks attachment. So when HIV is released, it cannot attach to new host cells in the presence of fusion inhibitors. Now there's a problem. This is like interferon. It requires like a once every 3 days IV type of injection. The side effects are horrible, and they don't use it unless nothing else works, because it's expensive and it takes massive amounts and the side effects are rough. So remember, if I ask you when would they use it, you would say last result. Now, what they have found is a new one, number 6. It's called CCR5 antagonist. And these block receptors, and they have no side effects. Now, you can't get this right now from your doctor. You can get it as a special request, but it is not easily available. So this is 5A, and 5B is CCR5 antagonist. And they don't have all the side bad things of fusion inhibitors. They do block attachment. And then the last one, and these are just out recently, are called Integrase Inhibitors. They are now available just recently. Remember the steps? The virus inserts its RNA into your cells. Reverse transcriptase converts RNA, viral RNA, to viral DNA. Then viral DNA integrates into your chromosome. This prevents integration of viral DNA. So the integrase inhibitors prevent integration. And they have been approved now, and I believe there is another class that's coming out. I don't think I have it on here. Yeah, the ones that are called salvage, they're called maturation inhibitors, but they're not approved. They prevent maturing of the particle. Yeah?
One of the test questions is asking about the significant disadvantage of the HARRT for 3-drug cocktail.
I'm going to get to that right now. There it is. What's the problem with HARRT? And the biggest problem is the protease inhibitors causes your cholesterol and your, what's the other thing with cholesterol? There's another, cholesterol and triglycerides to go off the map. In fact, people on protease inhibitors actually die of heart attacks a lot more than you expect. So they have to keep, for some reason, it just lets the cholesterol and triglycerides go crazy. Another one is these huge fat bubbles. If you've ever been around people that have been on protease inhibitors, some of them have something that looks like a golf ball under their skin. And so these are huge fat bubbles that are a side effect of protease inhibitors. They're on the forehead or on the arm or on the belly. They also get abdominal fat that is a side effect. So there's this sort of pear shape that even people that work out all the time get that are on protease inhibitors. It's called lipodystrophy. It means fat deposits in unusual places. So the bad thing about these antiretrovirals, the worst one is high cholesterol, high triglycerides, heart attack, lipodystrophy, and then some of them have the nucleoside RT inhibitors kill mitochondria. So you have to check for liver toxicity, you have to check for cholesterol, and you have to check for mitochondrial toxicity. And so if they find this, of course, they'll change you to another product. So what about, what's the answer to the question? Side effects is number one. These are the side effects. Number two used to be administration regimes. It is no longer the case. In the past, you would have to take 30 pills a day. And they have weird rules. Like some have to be taken with 1 quart of water. Some have to be taken 2 hours before you eat. Some have to be taken 1 hour after you eat. Some cannot be taken with milk products. The rules were outrageous. And here's the bad one. Miss 1 dose and they don't work anymore. 1 dose and they mutate. So that's why if you've ever been around people like friends of mine in West Hollywood, they'll be carrying these little pill boxes with timers on them. And wherever they're at, if it goes off, you'll see them stop and take the pill. Now, thank goodness, we've gotten around that because the pharmaceutical companies have gotten an adjustment and gotten it to 1 tablet a day. So we don't have the administration regimes problems anymore, but we still have the horrible side effects. And this is kind of scary because a lot of teenagers think that, you know, I go and talk about this stuff and they'll say, oh, I'm not really worried about HIV because I've seen all those magazine ads and those guys all have muscles and they look great. So I'll just take the HARRT therapy. They think it's an aspirin. And they think, oh, you know, no big deal. And there's a group of people that are gay that think that if you don't have HIV, you are weird and you're not a part of the community anymore. And they will actually go out and try to get it. They're called bug chasers. And they actually think that they're not really accepted if they don't have HIV. So there's a lot of twisted things going on in the way people look at the world. But the key point is you want to avoid this as much as possible, but if you get it, it's not the end of the world. Remember, if someone exactly like you, your identical twin, was diagnosed with diabetes, type 2 diabetes, on the same day you got HIV and you don't have diabetes, you would live longer. Because diabetes is harder to control than HIV. If you keep that viral load at 0, from the moment you know, it's amazing. And right now, with babies that are born, if they give them the HARRT therapy within a few hours after they're born, they have cleared. Which means if it lasts for 5 years, they're cured. Okay, so you have been tortured. The only thing you need is the vaccine video that we're going to talk about next time, and the parasites. So please look at the video of this lecture and the one that follows it, the last one that you'll be on tonight.
Wait, what? We're not
In other words, my next class, I'm continuing where I'm leaving off right now, and both of those will be posted tonight, so you can see this one you saw today, and the last one, which is vaccines and the 13 parasites. Right, next class. So I'm putting the videos up so you don't have to just look at the notes, you can see the videos of the lectures. And I'll put them up as soon as I finish lecturing tonight, about 10 o'clock. Did you get the letters back here? Sir, would you hit it off for me?